We're at the 7th conference at the IAS meeting in Kuala Lumpur, and we're here with Timmy Henrich, and he is with the partners and Brigham Women's Hospital, which is a teaching institution for Harvard Medical School, and you're working with Dr. Kritzkis.
Correct.
And it's really nice that we have you here today. You just left a press conference that was pretty, you were pretty much the kingpin in that discussion afterwards. And I thought the questions were all good too, because and we might even touch on those, but I think set us up, because the piece that you have is certainly not ready for prime time. You know?
That's correct. That is correct.
But it's the thing that I want to make sure the audience is aware of.
Okay.
This is science.
Correct.
It's a learning process, but it's so important and so riveting to the people who are there that understand what it is you're saying that is exciting. And I want you to get that out to these folks who are watching the program today, and give them that sense of excitement, as you did on the stage.
Okay, I will try my best. So I can give a little bit of background of what our study is and what the findings that we found. Essentially, we're updating some information on 2 patients that underwent a reduced intensity conditioning allogeneic stem cell transplant. It's a long word, or long series of words. Essentially, these are 2 men that had a long-standing HIV infection on long-term antiretroviral therapy that underwent a stem cell transplant with cells from donors donors from other patients, in other words, so from other individuals, so donor cells, not from themselves, but from others.
And this was, just for clarification, this is different than the Timothy Brown patient in that he did radiation.
That's correct. So these types of transplantations are a little bit different from what Timothy Ray Brown underwent in several fold. One is that they underwent a reduced intensity of chemotherapy before the transplantation. So they had lower levels of the cytotoxic or the toxic chemotherapy. They also did not receive total body irradiation, so they did not receive irradiation, and they do not get residual immune-based therapies to clear out residual lymphocyte cells from the system. So they actually have their own blood cells for about 6 to 9 months after the transplantation, so that's a little bit different.
But they do get replaced.
They do eventually get replaced. So what happens is those donor cells, although they're matched genetically for the patient, because you want them to be matched so they don't reject everything when they go in, what we think has happened, and what is that they've cleared out eventually over time, over that 6 to 9 month period. They recognize the residual host cells as being somewhat foreign or somewhat different, and have eventually cleared those out. And at least from our studies that we've done to date, show that nearly 100% of the cells in the peripheral blood are from the donor origin. They're not from the patient, but from the donor. In that situation. I should also mention that these cells that they received were also susceptible to HIV infection. So unlike Timothy Ray Brown or the Berlin patient, who had cells that had a mutation, that this CCR5 delta 32 that some people may have heard about, which essentially rendered those cells uninfectable by the strain of virus that Timothy Ray Brown had in his body before transplantation. In the opposite situation, our 2 patients actually had cells that were susceptible to HIV, did not have this mutation.
But they were being treated, so they were going to be kind of like new or virgin to this.
Exactly. So unlike Timothy Ray Brown, who stopped therapy right at the time of transplantation, we kept our patients, or the oncologist kept the patients, on antiretroviral therapy for years after that, during and after the transplantation. And what we think has happened is those donor cells, as they come in and as they replace those residual host blood cells that are left over, that they were protected from infection by this ongoing antiretroviral therapy. Very much like Timothy Ray Brown's cells were protected by the fact that they were intrinsically resistant to HIV. In our situation, they were susceptible, but they were on antiretroviral therapy. And I think this provides further evidence that antiretroviral therapy is capable of protecting, or fully protecting, uninfected cells in this situation.
Now, the measurements that you did, or the evaluation, the assays, so that you could determine infectable and infectious blood and so forth, you mentioned the 2 things were the gut, from the gut tissue. That was how did you perform that?
From one patient. That was actually from rectal biopsy.
Biopsies,
yeah, so fairly distal.
And then of course the peripherally circulating blood.
Correct. Yes, and we used a procedure to collect very, very, very high numbers of lymphocytes and other cells that could potentially harbor HIV infection.
You looked very closely.
Very closely. Yes.
Now, the question that I asked was other compartments, and I guess that was something that you had to just make a decision, and when you started out, whether this was going to be sufficient. to answer that question. But is there, to kind of follow up on that question I made, is there any way you could go back or would consider going back and doing more evaluation if this does not, to see if there was hidden compartments where virus was hiding?
So it's certainly possible that there could be virus hiding in other tissues, for example, the brain, liver, maybe other parts of the gut. The gut is very long, and we only biopsied a small portion, so it's certainly possible that there are other areas. Could it be in lymph nodes? It certainly could be. What we did do is, unfortunately, because these patients had transplantation, had cancer, that's now in remission, fortunately, they're both doing very well, and because that there are risks with active viral infection after transplantation that are well known, we felt that more invasive procedures would probably not appropriate at this time, at least in our patient population. They're also on intermittent to low-dose immunosuppressive medications, so as you're doing more and more biopsies and invasive procedures, you're potentially increasing risk of infection and other complications. So I think we did what we could to try to find in as much detail as possible without causing too much potential harm to the patient. Now that said, we have stored billions of the white blood cells or the mononuclear cells, these types of cells in the blood that can harbor HIV infection for future study. If, for example, when the virus comes back or if it comes back, we'll be able to go back and try to make a bit better of an understanding to see what's going on. And to share that with other researchers and other scientists who may be interested.
So you're now we're waiting for the next shoe to drop, whatever it might be. Is there? By the way, the work that you did was very. There was extensive and exhaustive preparation for this trial.
That's correct. For taking them off the therapy, yes.
Yeah,
for taking
ethics
them off
and informed consent, which must have made you crazy. But I mean, it's very important to do, especially with something that's cutting edge, unique. It was never done before. It's really, like you said. I guess the words were that it may actually be harmful. And you have to state that in the informed consent. But the gentlemen or women, we won't know, but whoever, are very much committed to this, and that you said, and
yes.
that is what we look at for patients when times come. It seems like there's always those people out there that are altruistic, and altruism. I've often thought, is it dying? But I think there are people that are out there that are really just committed to the fight and really want to give back.
They are. I think certainly our patients have had a large amount of altruism in participating in this study. I think with all cure research, though, to put it in a bit more perspective, that with cancer trials, when cancer trials enroll patients, they don't promise that they're going to be able to cure the patients. But I think there is some expectation that patients will benefit from the trials, and therefore will be willing to undergo toxic cytotoxic chemotherapies or unknown novel dangerous medications because they think there may be a chance for a cure or remission of their cancer. And I have a feeling that that's also the case with HIV curative trials as well. That although our patients are very understanding and I think understood the risk, that I think there is in everyone who approaches these types of trials underneath maybe really just feels like maybe I could be the one.
Right. They're just telling you all that bad news because they have to, right?
Right. There's something in there. So I don't want to extrapolate. I don't want to make any
But it is good that we have people who are willing to be altruistic, and I think that when we're looking, and this, the other thing that we looked at, and I think Jeff Berry brought it up, was that because this is very invasive. It's very, it's not for for everybody, and it's not something that's going to translate directly into the developing world. So we have to think about how is it translatable. Maybe it is in a different way that this can be done in another form. But I think. The thing whatever you learn from this will certainly be attributable to down the line work. It'll just be a part of the compendium of information we have.
Exactly. Yes.
Towards a cure.
Towards a cure.
Towards
That's correct. That's correct.
And so I think people are going to have to look at everything when they go into trials that are. I kind of tend that a lot of the trials won't say cure because they're nowhere close to it, but they're pieces of it. I think that's when we look at it, and all of it's important. The other gentleman and the two other women on the panel with you and the press conference also had pieces, and we'll be talking to two of them later. And they were, as albeit interesting, I think yours, was certainly more exciting. But I think I don't think we should quantify things like that, the things that are sexy and the things that are,
I completely agree.
all of it is so important. It's
all important. And even though that we're certainly getting a lot of attention, and our studies are, and our patients who are still confidential are getting all this attention through our study, you're absolutely right. This is just a small piece of the puzzle, that everybody has a piece, and each of those pieces in the long run may be equally, or if not more important than some of the other pieces. So, and even if, for example, that a year or two or even 3 years from now we're not able to detect HIV in the patients that we're following, this is not a scalable technology or procedure that we can do to most people with HIV. I mean, this is a toxic, dangerous procedure. It's expensive. It's something. It's a last resort, even in cancer therapy. So it is not scalable. But I agree with you that it helps us to learn about how we develop future strategies. What is the pathogenesis that we learn? How does HIV persist? How low of the HIV reservoir do we need to go to have a lasting difference? So it's going to help answer some of these questions. But you're right, it's just a single piece, and it will help us, like all the other pieces that have been presented at this conference that have been really exciting and interesting, on how we can develop and move forward from here.
Yeah. Do you agree with Steve Deeks that we're at 1987?
In terms of the cure, somewhat, yes.
Somewhere there, I think that's.
Yeah, we're at the very early stages where there's a little bit of exciting information coming out. There's now proof of concepts, at least, that may not be scalable, but there are a few. But at this point, that we're about to see this enormous amount of information learned and gained that will hopefully will be beneficial.
Yeah. So what do you do next? Other than wait? Is there other projects that you're working on, or at the same time? Or?
Oh, absolutely. So we're obviously waiting and following these patients very closely.
Diligently.
And, we're still enrolling patients, and we're also looking at patients with autologous stem cell transplant, with high-dose chemotherapy, without stem cell transplant. And we're also obviously looking at taking some of the preliminary information that we've learned, and we're designing and already carrying out a few studies to look at, for example, why we're seeing the phenomenon that we're seeing and why we're observing this, and how we can potentially use this phenomenon in a more scalable fashion. So certainly we're trying to use this for as a springboard for future study and future investigation, and hopefully that people will be interested in funding this type of work too.
Would you consider? How many? What are your collaborators?
So I collaborate with, this is a very collaborative study. So obviously the oncologists at the Dana-Farber Cancer Institute for our patients that we're presenting tomorrow, but also we're working with oncologists at the Massachusetts General Hospital, at the Beth Israel Deaconess Medical Center, other Harvard-affiliated hospitals in our area, all within this Harvard Cancer Center and catchment. We're working with folks at the Blood Research Systems Research Institute, Michael Bush and his colleagues out in California. We're collaborating with the Reagan Institute in Boston for immunology with Marcus Altfeld and with other folks there, so it's a very collaborative effort so far. And
do you work with NIH at all?
So I'm currently funded by the NIH to do part of the research that we are presenting, for sure. In addition, the Foundation for AIDS Research has also been very helpful in terms of providing extra support for this. But I do not. We are also planning on utilizing the NIH protocol for doing outgrowth assays, and we hope to be able to share some of our patient cells the next time that we collect a large number of these peripheral cells to send on to the NIH collaborators to look at that as well. So yes, so we do have plans to do that, direct interactions.
Well, Timothy, it's been very much a pleasure to share with our audience what you've done, and it's exciting, and we'll keep on watching, and certainly we'll hear from you about when the other shoe drops, as it were, and you learn what you learn.
Right. And no matter what happens, it's a
learning experience.
It's exciting, it's science, and
exactly.
Yes.
All right. Well,
thank you very
so
much.
much.
Thank you.